Breast cancer doesn't wait, and neither should you. I'm Hartford HealthCare's Tina Verona. Thank you so much for watching Connect to Healthier Live, our partnership with the Hartford Current. Well, screening mammograms and ultrasounds are absolutely vital in catching cancer early, when treatment can be effective and outcomes greater. It's a very important discussion we're having today, and I am so excited to have with me Dr. April Duckworth. She's a breast surgeon at the Hartford HealthCare Cancer Institute. Thank you, as always, for being here.
Oh, thank you for having me.
Yeah, we appreciate your expertise. I want to talk about trends. We're seeing more and more cases of breast cancer in younger women, even women who don't have a family history, which is an alarming trend.
Correct. It does seem that women are presenting much earlier, and they typically present after feeling a lump. Per pathologist, though, they say the average is still around like 62, 63, but I think it's because it's an average. It's not actually looking at the true number of the ages of the patients who are presenting.
Yeah, so and you mentioned lump, and we're going to get to kind of self-breast exams, so stay tuned for that. But I want to talk a little bit about, so kind of going chronologically, once a woman is diagnosed, it sort of sets this plethora of appointments that come all at once into motion. Can you take us through that process? And also, having a nurse navigator helping you through that process, I also think is critical. But take us through.
I agree. So typically after a person feels a lump, they see either their primary care, their gynecologist, who will start, either they'll refer directly to a breast center, or then we take over, or most will start by ordering the imaging. So they would start with doing a mammogram and an ultrasound. If an abnormality is seen, then they'll proceed with the biopsy. And the biopsy is where you actually get the diagnosis. Once you're diagnosed, then typically you see a breast surgeon, like me, who will go through your pathology and then kind of direct you on like the next stages, which depending on the type of breast cancer you have, it may start with surgery first, or it may start with chemo first. For the ones where most people, thankfully, start with surgery, and then once we get the final pathology, typically, depending on which surgical option they choose, they may or may not need radiation, and the vast majority of people, thankfully, don't even need chemo. They just need a hormone blocking pill.
And that's where that early detection comes into play, right?
Exactly.
So your treatments are a little bit less, you may have surgery, but you may not need radiation or chemo.
Correct.
So let's talk about what you do here at the Hartford HealthCare Cancer Institute. You're a breast surgeon. If a woman needs to see somebody like you, take us through that process now, that surgical process and some of the options. And I know a lot, of course, it's dependent on the grade of the cancer and the stage of the cancer, but if you can just kind of walk through some of those treatment options here at the Hartford HealthCare Cancer Institute.
So as far as like surgical options?
As far as surgical, yeah.
So there are pretty much only two surgeries one can do on the breast. One is to remove the area that has the cancer. That official name is a partial mastectomy, but if you talk to anyone in like the community, they typically call it lumpectomy. That's like option A. The other option is to remove the breast, and that's called a mastectomy. And at the end of the day, there's no survival difference between either surgery. So people live just as long whether they keep their breast or not. The difference is the local recurrence, which local recurrence even after a partial mastectomy is less than 10%. Whereas with the mastectomy, it's not zero, it's less than 2%. So at the end of the day, it's the person's choice what they want to do.
Yeah, and it's sometimes it's a difficult choice.
It's a very emotional choice.
It is, and so how do you sort of coach them through that process?
So each person has an independent value to their breast. Some people, their breast is just, a thing on their body, whether it's there or not, they don't really care, including the nipple too. Whereas you have other people where the nipple and having breast in their clothes is very, very important because it's part of their sexual identity.
Yeah.
And so that's where it really becomes a personal choice. I mean, now true, if the cancer is in multiple parts of the same breast, then your body has decided for you that it's need to go. Because at the end of the day, a woman is more important than any body part.
Yeah.
The person
It should not define you.
Exactly,
Yeah.
exactly.
What makes the care experience unique at the Cancer Institute? You know, we talk about, from day one, there's a nurse navigator, but the woman is never alone.
No.
Tell us about the experience and what makes it so special and unique here.
Yeah. So, going through cancer can feel very, very lonely because breast cancer, especially for women who do end up needing chemo, it robs you of your femininity. And so it can be a very long, deep, process where you're stuck in a very dark tunnel and you don't necessarily see the light. So thankfully, there is plenty of support. And it's, we have nurse navigators who that's their whole job is to help, remind you that, you're not doing this by yourself. You have a team, and we're all out to get you through the process.
Yeah, I want to talk about prevention, and of course, you mentioned finding a lump, but women play such a vital role in your own health, and breast exams really at any age, not just after 40, but even in your 20s. It's so important for you to know your body and know when something's wrong. So can you guide us through how to properly do a self-breast exam?
So what I recommend is you choose one day a month, and that's like a calendar day. So on the first of the month, you do your breast exam. Because if you try to time it with your cycle, we're all kind of all over the place. So you forget, and then you're doing a whole bunch of different times. So one day, so it's once a month. Otherwise, people drive themselves kind of crazy. But you start in the shower, and you take off your clothes, you look at yourself in the mirror like you normally do. You raise your arms to make sure that they hang the same way. You can even lean forward to see if there's any change in how they look. Check your bra, make sure that there's no discharge or anything on that. But then once you're in the shower, then when your hands are nice and soapy, usually it helps if you put your one arm up and then you choose a pattern. Each person has a preferred pattern, but the idea is that you touch the whole breast, the entire thing. So whether you do kind of like a lawnmower where you start and then you kind of go back, or you start in the middle and you go in circular motion, or you choose your pattern and stick with it. And that's the way that you do it. When you feel a lump, because our breasts have lumps, that's kind of what they do. But scary ones, you will notice in one direction, and then if you feel it this way, you're like, oh, there's something there, and then you try a different way, and you're like, oh, something's still there. You try it a different way, oh, something is still there, and you check it 2 days later, and it's still there. Then call your doctor.
And should you be doing it with your menstrual cycle? Is it because sometimes you hear that you could?
Yeah, well, I find
it could affect that.
Yeah, well, in the ideal world, we would all be regular, but when you put in IUDs, birth control, and just some people are irregular.
Yeah.
So trying to keep track of that becomes very difficult. So then you find that some people are just checking themselves nonstop, and you don't need to have we have enough stuff going on in life.
Yeah.
So that's why I find sticking with a calendar date.
Yeah.
It helps because then you're like, oh, today is the 15th of the month. I do my breast exam.
Yeah.
And then on the 20th, you'd be like, did I do it? You're like, nope, I did it because it was the 15th.
It was the 15th. Keep it on that routine, that schedule. You don't forget. We do have a question coming in from a viewer, Irene. She asks, what about if you don't have a PCP, a primary care physician? Is there any way to still get a mammogram? Thanks, Irene, for the question.
Yeah, so any of the imaging places, as long as it's a screening that you're looking for, doesn't necessarily need an order. So you can call and they should be able to schedule you.
And there's also,
and you have the mobile
we have the mobile mammography unit that all this month is making appearances at different areas, and there is a calendar. If you go to hartfordhealthcare.org/breast cancer, there should be a calendar there of where that mobile mammography is. It's all over the state, so that's another great way. Let's talk about genetic testing, and when it comes to that, what are the current guidelines, and how much does family history influence that breast cancer risk nowadays?
So family history is by far the like one of the influential reasons why someone would be considered high risk. I mean, if they have a positive biopsy for high risk lesion, it's a different story. But family history trumps a negative genetic test any day. The reason is that we only know so many genes that are associated with breast cancer, and most women actually have no genetic mutation when they have breast cancer.
What about a woman who's diagnosed with breast cancer and the correlation with, ovarian cancer or cervical cancer?
So that's where the genetics really do come into play, because there are certain mutations which increase, fallopian tube and ovarian. So the BRCAs, they're also associated with like male breast cancer, as well as melanoma and pancreatic. Then you have other mutations that are associated with stomach cancer in addition. But if a woman is diagnosed under the age of 50, they'll qualify for genetic testing. Also, if they have a first-degree relative that has breast, if they have any relative who has ovarian, or if they have a male relative who has prostate cancer that's of a certain level, then they would qualify for genetic testing.
They would qualify. And for some women, there's enhanced screening that may be recommended, maybe MRIs or so forth after a diagnosis. When is that necessary, and what does that usually involve?
So for women who have strong family histories, so that their lifetime risk is 20% or higher, then they qualify for, in addition to their annual mammo and a dense ultrasound, they'll also qualify for either an MRI, or nowadays we also have a contrast enhanced mammogram, which is almost as good as the MRI, but it's a very close second. But it's significantly easier to do on the patient.
On the patient, yeah. So I want to clear up some confusion now. We hear of biggest misconceptions about breast cancer risks. What should people know about the risks? What do you believe? What do you don't believe?
Well, so as far as, like eating sugar, for instance, everything in moderation, like the diet, don't put on 500 pounds, keep a healthy lifestyle, have healthy size. But the biggest misconception I feel is that a young woman, so in their 20s or 30s, will feel a lump and they'll be told that it's nothing. But in reality, it's something. Or, they have a lump, they get imaging, and the imaging is negative. So they think falsely, oh, I'm good because I have negative imaging, it's nothing there, it's just in my head. But they actually feel something. They have to be a self-advocate and keep getting to someone that is actually listening to them.
Yeah. And while we have this active audience with us, what's the one thing you could say to them? Because, and you see it every day. You see, women coming in that may not have had a mammogram or is in a late stage diagnosis. How do you prevent that? What's the one thing or anything that you can say to the audience now to stress how important it is to have that early detection, because you have a fighting chance?
Yeah, well, so most people do very well with breast cancer. It's not a death sentence. And it really is key, early detection, because the smaller it is, the more curable it is. And also the less that you have to do. Because if you find it when it's non-invasive, sometimes all you need is a surgery and you're done. Versus when it's a large mass that's got multiple lymph nodes, then you're looking at chemo, radiation, a bigger surgery. So when it's nice and small, it's a lot easier to treat.
It's much more manageable.
But either way, most women thankfully do very well. We survive breast cancer and we go on to live fulfilling lives. So it's like you said, this diagnosis is part of one's story, but it's not defining the person.
Yeah, absolutely. And what do you say to those women, and I know some women who are like this, who say, I don't want to go for my mammogram because I just don't want to know the results? How do you get that woman in there for a mammogram?
Yeah, I mean, it's tough. Then I try to find out why they don't necessarily want to do the mammogram and try to figure out kind of the workarounds. Be like, well, if you don't want the compression, then let's start with an ultrasound and we'll go from there. Or, maybe we'll stagger things so that can really kind of accommodate, because at the end of the day, it is their body.
Yeah.
And they get to decide what happens to it.
Mm-hmm.
But I do strongly encourage to get your mammogram. And if you have to choose one imaging out of all of them, do the mammogram.
That's still the gold standard.
It's the easiest one to do, and it picks up things very well. So.
But now, if you have dense breasts, you have to have that screening ultrasound as well as the mammogram.
Yeah, and it's like the mammogram is really good at seeing distortions and pieces of calcium, which that's how most breast cancers are found. The ultrasound is really good at seeing like cysts and masses. So, but the problem with the ultrasound is it depends on the person who's doing it. Thankfully, with the radiology groups that are here, they have techs who are very experienced. So, but if you're at, some very small place that doesn't do a lot of breast ultrasounds, they can miss a lot.
Well, yeah, and I think that's important, and that's where you become your own advocate too. But I think the experience really comes into play there, and I think that's probably a really important defining key differentiator here, is that the radiologists are so experienced, because if it passes through the radiologist and they don't catch it, and you have this sort of, you're going on your merry way thinking I'm good, when you might not be. So can you talk a little bit about that? I think that's such a critical aspect of this whole journey.
Yeah, no, I mean, it's very true, because I have had many patients who come to me that have like a probable benign imaging finding. And I mean, if they're seeing me for the probable benign, it tells me automatically that they think something more is going there on. So typically, like, I have a very low threshold to biopsy those, because if someone is like, this doesn't feel right, usually they're right. Like, it's interesting.
Yeah, you always have to kind of go with your gut, right?
Yeah.
And how you're feeling. And again, it goes back to knowing your body.
Yeah, but also waiting 6 months when you're already questioning, like, that's a long time to wait.
Yeah.
Like, that's a lot of sleepless nights.
Yeah.
Your breast should not cause you sleepless nights.
Yeah, no, exactly. And I think that's such a critical part of the process, is knowing your body and knowing when to take that next step, and having somebody like yourself. So when a woman gets that, sort of, she has her mammogram, let's say she has her mammogram ultrasound, something suspicious, but they're like, yeah, come back in 6 months. Do you recommend they get a second opinion, or what do you recommend?
Well, I think if the person, because like I said, people tend to know if something's off.
Yeah.
If they're like, this doesn't feel right to me, then they should definitely get a second opinion.
Yeah. All right. Well, April Duckworth, thank you so much for your time and your expertise. It's always a pleasure to have you.
Yeah. Well, thank you for having me, and get your breast checked.
Absolutely. And for more information on everything that we've discussed, you can just simply visit hartfordhealthcare.org/mammogram to sign up for a mammogram if you haven't. I'm Hartford HealthCare's Tina Verona. Thank you so much for watching today. It's been a pleasure. We'll see you real soon. But for now, be well.